Hey, hello, I am Andrea Furlan. I am an associate professor of medicine in the Department of Physical Medicine Rehab at the University of Toronto. And I'm also here representing the Institute for Kidney Health, the Toronto Rehabilitation Institute from UHN, and I'm the chair of Project ECHO Ontario, Chronic Pain and Opioid Stewardship, which is a mentoring program of specialists teaching clinicians in remote, underserved areas of Ontario. And it's my pleasure to talk to you today. I'll talk about classification of chronic pain, primary pain, secondary pain, and the new classification from the WHO. So thank you for inviting me to be here today. So in summary, this presentation, I hope that at the end of this talk, you will be more knowledgeable about chronic pain as a major source of suffering and leading cause of disability worldwide. Also, I hope you will be, probably already know this, but I will explain the 11th version of the International Classification of Diseases, the ICD, that defines chronic pain as a disease. And it's not just a symptom. Primary pain is not just a symptom of something that is wrong, but it's a disease in itself. And it is defined as pain that persists or recurs for more than 3 months, but it can be primary or secondary. And also, I will talk about the International Classification of Functioning that complements the ICD, has a functioning properties. So what I want to explain today is more about describing the pain system. What are the targets for therapy, using methods to examine central sensitization, and again, as I said, explain the types of pain in the ICD-11. So what is pain? So let's talk about the basic definition of what is pain. We all felt pain in our lives. It's impossible not to feel pain. It's part of the human being, animals. We all feel pain because it's protective. And the first time that someone kind of described the system, what's going on in our body, was René Descartes in the 17th century, where he described saying, you know, if you put out your toe, your finger on the fire, for example, there will be an electrical impulse. There will be some message going up to the brain and alerting the brain that something's wrong. So that was the first time that someone realized the pain is felt in the brain. So now in the 21st century, more discoveries were made regarding the pain system. And it's not just an impulse that goes up, but the brain has a lot of capacity to change with that impulse, with that information. So a lot of things happen in the brain, and the brain also does a lot of meaning, interpretation of that sensation. But the brain is also important in activating, the green arrow here is the descending inhibitory pathways. So we will see that this is the pain system. So the same way that we have a digestive system, cardiovascular system, reproductive system, immunological system, we have a pain system in our body, which is the alarm system of our body to show if something is wrong with our body, okay? And so in the last 56 years is really when the pain system has been, I would say, discovered and described. So it's kind of a new discovery for medicine compared to all the other systems. The digestive, cardiovascular system are kind of old. They were described 300, 400 years ago, but the pain system is new. It's just 60 years old. And a lot of studies are now being conducted to describe the pathologies, the aberrations that happen, and the diseases that can happen in the pain system. So if we classify these diseases according to location, where they happen, we can say that there are diseases of the pain system that occur in the periphery, in the spinal cord, and in the brain, and many others. There are also conditions that affect the immunological system, the endocrinological system, and so they are connected with the neurological system. So we'll talk a little bit about the peripheral sensitization, central sensitization, and cortical reorganization. So first, what happens in the periphery? And what are the changes? And these changes happen very quickly. They're not just chronic pain is 3 months or more, but these changes happen very quickly. So we'll see a little bit about what is that they do here, right? So these are physiological pain starts in the peripheral terminals of the nociceptors, right? With the activation of nociceptive transducer and receptor and ion channel complexes. And they generate depolarizing currents in response to noxious stimuli. And this can be in the skin, in the organs, anywhere that we have this depolarization of neurons. And you see here, it can be activated by many different types of sensory stimulus, like heat, mechanical, chemical. And actually, you probably heard last year, 2021, David Julius won the Nobel Prize of Medicine for his work over the last 20 years, describing these receptors for pain. He was the one who discovered, described, and characterized the heat receptors. And he used capsaicin as a method for finding and describing these receptors. So this one, it's an amazing discovery. And you see, it's a new thing for medicine in the last 20 years. So the 3 forms of neuroplasticity that increase gain in the somatosensory system to produce pain sensitivity, hypersensitivity, are basically, we can classify them into activation, modulation, and modification. So neuroplasticity is in primary sensory neurons include these methods. I don't have time to go into details of this, but I put the paper here if you want to read more. This is an excellent paper summarizing what happens in the periphery in terms of what happens in the activation, modulation, and modification of all these nociceptors, peripheral terminals, thresholds. So I'll jump now to the spinal cord. I know that was a quick overview of sensitization at the peripheral nerve. So here is I love this paper by Dr. Clifford Wolf. He had been, amazing in describing central sensitization, and he's an amazing scientist that has discovered many pathways and describe them, what happens in the spinal cord. So I'll try to explain this paper to you. This is quite a simplified diagram. I spoke to him a couple of years ago and he said, Andrea, this is kind of outdated, but I love these diagrams because they explain very well. So this is the neuron coming from the periphery here, bringing nociceptive information. So at the synapses in the spinal cord, that neuron will release a lot of neurotransmitters and will activate the postsynaptic neuron that will then travel to the brain. And we know that there is a third neuron there, sitting there, that is the inhibitory neuron. And this third neuron is activated or deactivated by the brain. And this third neuron is able to modulate what's going on in this synapses, increasing the volume or decreasing the volume, okay? So what happens is in the acute phase of central sensitization, and again, this can happen very quickly, a couple of days, this can happen, this changes. The early phases of central sensitization is a form of activity-dependent synaptic plasticity, and it's driven by high levels of nociceptor input that via this transmitter release and action on the multiple receptors expressed on the dorsal horn cells, they result in activation of intracellular kinases. So this intracellular kinase will then phosphorylate ion channels and receptors. So they alter the distribution and function and increase the excitability and thereby pain sensitivity. So you see there's more activity of this synapses. This is called pain hypersensitivity. Then we have the late phase. And the late phase you see here, this is the delayed phase of central sensitization that involves changes in the transcription in the dorsal horn neuron. So here we have genetic changes. And this is gene expression that are activity driven. And And this is also widespread, like the induction of cyclooxygenase 2 in the central neurons after peripheral inflammation. So you see here, it's not activity dependent anymore. We don't need the neuron coming from the periphery bringing information of pain, which means the pain in the periphery has stopped. The injury is healed. The disease is treated. The bone fracture is healed. The appendicitis is gone. The hernia, inguinal hernia repair, the surgery is done, healed, gone. But that synapses is still active. So this is where we start having osteoplastic pain, because now we don't need the peripheral, we don't need the nociceptive pain anymore. The synapses maintains itself. And the last phase of central sensitization is when basically you lose the inhibitory neuron. So the inhibitory interneurons that plays a major role in damping down the sensory processing. So after we have a peripheral nerve lesion, we know that there is reduction in the action of an inhibitory transmitter and loss of aminobutyric acid mediated interneurons. So this is basically GABA neurons, and we lose them. And now we have a synapses that is going on itself, activating itself, and no ability anymore of the brain or any other system to inhibit that synapses. So here, basically, the plasticity is permanent. Well, I think there's always a component that we can revert plasticity, but here you can imagine this is quite hard. Okay, if that's not enough, we also have a lot of changes in the brain. And I would bring here a lot of papers by Dr. Vanya Apikarian. He is an amazing researcher from Western University in Chicago. And he has done amazing work in this area. For example, many years ago, he published this paper, many years ago, showing that they compared the brain morphology of people with chronic back pain and matched control subjects, and they used magnetic resonance imaging brain scans. And they did an automated analysis technique. So the computer was interpreting these MRIs. It was not human eyes, it was the computer. So the chronic back pain patients were divided into those who had a neuropathic component, exhibiting pain because of a sciatic nerve damage, and those that did not have a neuropathic component. What they showed was patients with chronic back pain, they had a 5 to 11% less neocortical gray matter volume than the control subjects. So the brain is smaller. And the magnitude of this decrease is equivalent to the gray matter volume lost in 10 to 20 years normal aging. So this is really serious, because if you have a patient with chronic back pain, their brain is aged about 10 to 20 years just because of those changes in the cortical reorganization, okay? So here these authors, they use a resting state functional magnetic resonance imaging to investigate functional changes in patients with chronic back pain, but also there were 3 groups: chronic back pain, complex regional pain syndrome, CRPS, and knee osteoarthritis in a normal group. So the first column here are all the functional MRIs of healthy controls, chronic back pain here, CRPS, and osteoarthritis of the knee. So the computer was interpreting these MRIs, not the human eye. The human eye cannot see a lot of difference. But what is interesting is that the computer is able to isolate 5 meaningful resting state networks across the groups. And not only, one is the default mode network, the DMN, and the default mode network exhibited deviations from healthy controls. All patient groups showed decreased connectivity of the medial prefrontal cortex to the posterior constituents of the default mode network, the DMN. And they also had, look at this, they had increased connectivity to the insular cortex in proportion to the intensity of pain. Multiple DMN regions here, especially the MPFC, exhibited increased high-frequency oscillations and decreased phase locking with parietal regions involved in processing attention. What this all means is that chronic pain seems to reorganize the dynamics of the DMN, and as such, they reflect a maladaptive physiology of different types of pain. So basically, there are changes in the connections of the brain, and these connections are different according to the intensity of pain and the type of pain. So the computer basically can detect what kind of pain the person is having. Is this a CRPS, chronic back pain, osteoarthritis, or is this a normal individual? So this is another picture of the functional reorganization across many different chronic pain conditions. Okay, if that's not enough, as I mentioned to you, not just the neurological system is affected, but the neuroendocrine and the neuroimmunological systems are also involved and altered. So this paper published in Frontiers in Cellular Neuroscience recently, 2018, is a very nice summary of all these alterations. I'll just describe here quickly. So under normal conditions, an acute stressor, this is a normal brain, okay? Normal brain. The acute stressor here will signal the paraventricular nucleus, the PVN of the hypothalamus to release corticotrophin release factor, CRF, into the hypophyseal portal veins, which cause the anterior pituitary gland to release ACTH, right? And then this ACTH signals the adrenal cortex to release glucocorticoid that have downstream metabolic effects. And we know that there is a negative feedback loop, will turn off activation of the hypothalamic pituitary adrenal HPA axis by suppressing the production of CRF and ACTH upon cessation of the initial stressor, okay? The hippocampus and the amygdala play an important inhibitory and excitatory roles in regulation of the HP axis, respectively. So the hippocampus is inhibitory and the amygdala is excitatory, okay? CRF is released upon this HPA axis activation and also has peripheral effects. We know mast cells, these MCs here, mast cells, can become activated by CRF, causing the release of cytokines and growth factors that they have reciprocal interactions with the peripheral nociceptors. So we know that nociceptor activation will signal through the dorsal horn of the spinal cord. This is the spinal cord here, leading to activation of the supraspinal somatosensory brain regions. So then we have the red arrow here is activation from the spinal cord to the supraspinal somatosensory brain regions, and the blue arrow here going down is the descending pain pathways that plays a role in the regulation of the painful experiences. Okay, this is normal. Now let's see what happens in a sensitized condition. So we know that if the person is under stress, a lot of anxiety, fear, or a present stress or fear, or if this person had early childhood adverse experiences, so chronic stress in the early lives when the brain was developing, these mechanisms are not functioning properly and they perpetuate pain. So they're involved in the chronification of pain. Let's see what is happening here. So bear with me, it's a lot of descriptions here, but this is super exciting because this explains why we have those difficult patients with nociplastic pain, primary pain, that do not respond well to the therapies that we give to them, injections, drugs, surgery. It seems that the more you do, the worse they get. That's because you're trying to use an intervention that works when the pain system is normal. Now, when the pain system has all these aberrations that I mentioned to you, the periphery, the spinal cord, the brain, you try to do those interventions, they don't work the same way. So you need to fix the pain system instead of giving them more opioids or more injections or more surgery. Okay? So here, chronic early life or adult stress leads to alteration in the limbic regulation of the HPA axis. And this is due to increased CRF expression and drive from the amygdala. So the amygdala here is super important, okay? And there is decreased glucocorticoid receptor and brain-derived neurotrophic factor expression in the hippocampus, which dampens inhibition. So you basically lose the hippocampus that inhibits this whole thing here, and you activate the amygdala, which was already an excitatory part of the brain, right? So these changes ultimately lead to increased CRF release from the hypothalamus, increase and prolonged release of ACTH, even after the cessation of the stressor. Did you hear that? Even after the stressor is finished, we still have these pathways going on and on and on. Okay? So increased CRF release leads to greater mast cell activation and infiltration, leading to enhanced peripheral nociceptor interaction. So this increased peripheral drive can lead to a hyperalgesic priming and or wind-up phenomenon, eventually increasing the ascending pain signals. You see now the red arrow going up is very strong, and decreasing, kind of inhibiting, and kind of you lose the ability to activate the descending pain pathways. Okay, later in this talk, I'll talk to you about how we can fix this. I'll bring this diagram again with good news. We know how to fix this pain system, okay? So bear with me and I'll show this slide to you later. So we know that this in the middle here is this amplified widespread pain. This is called central sensitization, and the symptoms that the person will exhibit: fatigue, sleep disturbance, autonomic disturbances, mood symptoms, somatic symptoms like migraines, irritable bowels, cognitive difficulties. So these are all, this means that the brain, this person was predisposed by genetic influences, biologic factors, environmental factors. So all of this now is disrupted, and all of this have consequences. We have decreased physical function, school absence, activity avoidance, difficulties in peer relationships, difficulty in family relationships, poor coping strategies, and decreased quality of life. So here, to summarize, pain is protective. We all need to feel pain. We know that congenital analgesia is a disease, very rare, but people who are born without the ability to feel pain, they die in early age because we need pain to survive. But when chronic pain is a disease of the pain system, it's not protective anymore, it's just noise. And I tell my patients, I compare pain to the alarm system of the house. And I say, you know, you install sensors in your house for burglar, fire, carbon monoxide detector, medical emergencies. They all send the signals to a box, and that box on your house will send a telephone line to the central alarm system, and the central alarm system office will decide, do I send the police, the fire, or the ambulance? And indoor pain system is the same. We have all these nociceptors in our skin, in our internal organs, in our bones to detect pain. And they all send information to the spinal cord. Of course, from the face and the head, they don't go to the spinal cord, they go directly to the brain through the cranial nerves. And from the spinal cord, they send the information to the brain, and the brain decides what to do, which descending inhibitory pathways I will send, and then blocks the pain. Of course, if we have a disease of this alarm system, if the alarm system is malfunctioning, then you're not going to look for the fire. Say, where's the fire? I need to put off the fire. No, there's no fire in the house. If you keep looking for the fire, you never find. You need to treat the pain system. So the house is not on fire. And I see a lot of physicians trying to treat the pain that doesn't exist anymore. So they try to do injections in the knee, surgery in the knee, and do everything in the knee or the hip or the foot. The pain is not there anymore. The pain is in the pain system. Okay, we need to fix the pain system. So that's why chronic pain is challenging to treat, because not a lot of physicians know how to treat chronic pain. They don't know the difference between nociceptive, neuropathic, and nociplastic pain. And central sensitization is defined as an amplification of neural signaling within the central nervous system that elicits pain hypersensitivity. Chronic pain is one of the most underestimated healthcare problems in the world today. And again, sometimes it's so simple to treat. It's just make the diagnosis. If it's nociceptive, it's a fire in the house, go there and put up the fire. If it's neuropathic, treat the neuropathic pathways. But if it's nociplastic, you need to fix the pain system. Stop treating the periphery. Chronic pain affects 1 in 5 adults and 1 in 3 seniors. So here is the new classification, the WHO, World Health Organization, just released recently. And this is the ICD-11, the International Classification of Disease. So now they recognize pain, chronic pain, is a disease on itself. Not all chronic pains are nociplastic, okay? Remember this. That's why we need good pain doctors. And I'm so glad that in Ukraine, you have an amazing pain society, because you are training your doctors really well. I'm amazed by your programs and what you are doing. Congratulations. We need doctors who know this difference. When is it nociceptive? When is neuropathic? When is nociplastic? But don't treat them, especially chronic pain. Don't treat a nociplastic pain that has central sensitization as if it was nociceptive or neuropathic. So what is primary pain? Primary pain is basically a disease of the pain system. So, and it can affect many anatomical regions. So this is defined as pain that recurs longer than 3 months, because almost all acute pain can be healed, treated within 3 months. Of course, we'll have nociceptive pain that will persist longer. We'll always have those patients that will have a constant nociceptive pain. And this can be inflammatory arthritis that is constantly irritating the joint. This can be cancer pain, that the tumor is always growing and irritating the nerves, causing neuropathic pain, or the tumor is growing and pressuring some structures, causing nociceptive pain. So there are a couple of different conditions that can be chronic, but think about this. Is it nociceptive? Is it primary pain? And you know this by examining the individual, talking to the individual, because primary pain has a lot of emotional distress because it's a disease of the brain. It's not just, the person is depressed because they have pain every day. No. Depression is part of the syndrome. The brain is with all those changes that happen in the brain, depression, anxiety, frustration is all part of the syndrome. And they have functional disability that interferes with activities of daily life, participation in their functional social roles. The symptoms are not better accounted for any other diagnosis. And here are some examples: chronic widespread pain, fibromyalgia, complex regional pain syndrome, chronic primary headache, migraines, or facial pain known as TMJ dysfunction, chronic primary visceral pain, irritable bowel syndrome, chronic primary musculoskeletal pains. So all of these are primary pains. So here it is, if you want to read more about this, and this is the classification of functioning that also helps us to identify the physical, mental, and social well-beings are part of this new classification of pain, okay? So not all chronic pains are the same. you have chronic pain without central sensitization and chronic pain with central sensitization. So you can have secondary and primary pain. And if you read the papers from the ICD-11, there are many papers published and you will be very well explained. But here, for example, if you have a chronic nociceptive pain, chronic neuropathic pain only without any aspect of central sensitization, which is rare, but it can happen, then you have a way of treating this as a chronic pain. Now, if you examine the patient, if you talk to the patient, you will know when they have central sensitization because they have many signs, abnormal psychological response, difficult to concentrate, to sleep. And this pain is not protecting them. It's just noise. Never tell the patient, please don't tell the patient that the pain is in your head and this is psychological pain. And just if you think differently, you will get better. No, that's not the message. You have to validate that all chronic pains are real. All chronic pains are real. They're not faking it. They're not making it up. Never tell a patient has chronic migraines. Oh, you're making this up. This is just some changes in your brain. Well, it's true. It's just some changes in their brain, in the immunological system, in the endocrinological system, but they're not faking it. They're not making it up, okay? All pains are real. Validate your patient's experience and acknowledge that they are suffering. This pain is real. And the worst thing for nociplastic pain is that nobody can see it. Nobody can demonstrate yet because we don't do functional MRIs in our clinics yet. But the patient will feel very validated by you if they know that you know what they are going through. And they will adhere to your treatment if they know you know about that disease, okay? So that part of the conversation is really important, that the patients will understand what they have and that you explain to them, because if they think you don't know what they have, they will not adhere to your treatment. So how do we diagnose primary pain? Give them a pain diagram. This is the pain diagram that I give to all of my patients. Ask them to paint where they have pain. So if they color this parts here, I will look at this and say, I think this is secondary pain. It's not primary pain. This looks more like arthritis. They're painting the joints. Now, if someone paints their pain like this, I'll say, this seems more like a primary pain with central sensitization. But this is not just the only thing that you do. You take the history and you examine them and you find a lot of hyperalgesia, hypoalgesia, things that don't follow some dermatomal distribution or peripheral nerve distribution. So the symptoms, what the patients will complain is this hypersensitivity to bright light, to noise, to touch, smells, food, mechanical pressure. They have side effects with a lot of medications. They are always sensitive to changes in temperature, changes in the weather. That's because their brain is sensitized. They have widespread pain, fatigue, mental and physical fatigue, sleep disturbances. They feel numbness in some areas of the body. They have some swelling sensations, low libido, low mood, because remember, this is a disease of the pain system. And then you confirm with a physical exam. So get your tools. I use a paper Kleenex and a Sharpie tools, and I do test their sensations, peripheral sensations, the whole body. So they undress, and I start here with the forefront, with the light touch, and then I go down the body. And what is that I'm looking for when I do this exam? Well, this is not what I'm looking for. If I find like a hemi body, touch, hyposensitivity, this is a stroke, right? So the first one here, A, is a contralateral thalamic or parietal stroke. B, if I find B, like temperature and pain is hypo in one side of the body from the neck down, but the contralateral side on the face, this is a Wallenberg syndrome. This is dorsolateral medulla stroke. This is not central sensitization. C is spinal cord injury. D, what is D? Is a Bronze cord syndrome, which is a lesion of one half of the spinal cord. E is a lesion of the spinothalamic tract. F is a lesion of the posterior column. And G is a somatosensory deficit, like radiculopathy. And H is peripheral neuropathy. It could be diabetes or alcohol or vitamin B12 deficiency. And on the right here, the color pictures are showing distribution of the peripheral nerves: median nerve, radial nerve, ulnar nerve, peroneal nerve, tibial nerve. So if you find things that follow a dermatome or follow one of these distributions, this is not central sensitization. This is neurological disease. This is neuropathic pain. Now, this is central sensitization. It doesn't follow. You do your physical exam to pinprick and light touch, and it doesn't follow a dermatome, doesn't follow peripheral nerve. You have hypo and hyper sometimes in the same territory, and it changes. It changes in the same day, or a week later you repeat this test and it's changed, and it progresses with time. So the longer the chronic pain stays, this usually tends to amplify and spread in distribution. And Dr. Angela Maylis-Gagnon from Toronto, she has a paper that she described a number of cases of sensory abnormalities and in chronic pain. Okay. And I have a video on my YouTube channel that I explain to the patients what is central sensitization, because they have very difficulty to understand what it is. And they are so, I would say those patients are so disappointed with the medical profession because they go from doctor to doctor to doctor and nobody knows what they have. Nobody ever explained to them. Nobody ever examined them for nociplastic pain central sensitization. I recently also released another video for patients. These are videos that I create for my patients about what is central sensitization and what is nociceptive pain, nociplastic pain, and neuropathic pain. So I will finish here, but before I finish, I'd like to say that the treatment for fixing the pain system that I told you that I was going to talk about, it was not originally included in my talk, but I will include. So the treatment for fixing the pain system that we know it works are basically two things. And when I tell my patients these two things, they kind of get disappointed, but happy, because I tell them there is a treatment for fixing the pain system. This is the good news. But the treatment involves mind-body therapies and exercises. So cognitive behavior therapy, mindfulness, meditation, brain retraining, acceptance commitment therapy. These are things that patients can retrain their pain sensations and tell their brain what's going on, what am I fearful of? Because we know a lot of patients will avoid moving. They will become paralyzed by pain, very fearful of doing any activity, of going out and living their life. So this mind-body therapies will help them to think differently and start engaging in activities. And as they progress, they see that they can do these activities without aggravating pain. Or even if aggravates pain, it doesn't mean that they're harming their body. They are retraining their pain system. Okay, so movement and mind-body therapies. Those are the things that really work for fixing the pain system. And medications are not really helpful. In fact, when we diagnose a person with nociplastic pain, we start reducing their medications. We start removing medications because they come on polypharmacy. And then they start feeling better because all of those side effects that they were having with opioids, antidepressants, anticonvulsants, cannabinoids, anti-inflammatories, they were just causing a lot of side effects and not helping the pain at all. But once the patient starts doing mind-body therapies and exercising and moving, it's tremendous the amount of pain relief they have. So this is the message that I like to give to you, and I will stop here. And I hope you enjoyed the conference. And if you have any questions, please, you have my contact in the first slide. And I'll be happy to get in touch with you. Thank you so much again for inviting me. And I wish you all the best for your society in Ukraine.